Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a very complex procedure performed in a 100-year-old patient, believe it or not. And the patient was referred to me by another specialist because they struggled to gain access into their ear. And you can see this is their left ear. The ear canal entrance is completely collapsed. They actually do wear a hearing aid, and they've got a moulded piece, and they can push the moulded piece through the entrance of the ear canal. So the outer third of the ear canal is cartilaginous, so it is semi-flexible, and so they are able to actually insert the hearing aid, but currently they're not able to wear the hearing aid because their ear is completely blocked with wax. In addition, and you'll see as the procedure evolves, I noted some ear ulcerations at the floor of the ear canal. That will need further investigation. That could either just be just the skin that lines the ear canal has died away, which then it exposes the bone, and we can call that, and it's not infected, we call that benign osteotitis, or it could be a bit more of a rarer condition called a canal cholesteatoma. So what we're doing here, I'm having to use a fine end suction probe. You wouldn't be able to fit a normal suction probe into this patient's ear because it's so narrow, and you can see despite the entrance of the ear canal being completely shut, I'm still able to gain access in the ear. It is difficult, but I am able to gain access, and there's a lot of wax but also a lot of dead skin. And no doubt what's happening with this patient is that the skin that lines the ear canal in the eardrum, as it dies and sheds, as it should, and it should normally then migrate out of the ear like a conveyor belt. So the skin from the eardrum, as it dies and sheds, it moves sideways across the ear canal towards the entrance and eventually out of the ear at a rate around 3 millimeters a month, similar to the growth of our fingernails. But what's happening is this skin is not fully migrating, and it's collecting, and particularly at the base of the ear canal, this skin is collecting into little pits and divots. It's got infected, and it's starting to then expose the underlying bone. And what a canal cholesteatoma is now, a cholesteatoma is normally associated with a growth of a infected skin plug in the attic region of the eardrum, more specifically the back superior regions. We call it the posterior superior quadrant. So if you're looking at the eardrum, in the case of this, the left ear, a pocket on the eardrum normally forms. So it will be northeast in the case of the left ear, and in the case of the right ear, it will be northwest. And the eardrum buckles inwards, and that's because of negative middle ear pressure, and that's due to a blocked Eustachian tube. Behind the ear canal, there's a tube that connects the middle ear, which is a cavity behind the eardrum, to the back of the nose, and that's called the Eustachian tube. Not only is it a drainage tube, so any fluid that collects behind the eardrum can drain away, it's also the pressure equalizer in the ear. So we want the air pressure behind the eardrum in the middle ear to be the equivalent to the air pressure in the atmosphere, so in the ear canal. And when the air pressure either side of the eardrum is equal, that's when the eardrum is most mobile. It's most compliant, that's when we hear the best. So that's the function of the Eustachian tube. And if the Eustachian tube gets blocked, and it normally gets blocked at the back of the nose, there's no air behind the eardrum. Air can't enter the middle ear via the Eustachian tube because it's blocked. So that creates a vacuum effect, and the eardrum gets sucked in, and it normally gets sucked in, as I said, in the case of the left ear, in the northeast region, so the top rear aspect, and similarly in the right ear, it's the top rear aspect, so that'd be northwest. And the eardrum there, it's a bit more flaccid, so it gets sucked in, and that creates a pocket. So as the skin from the eardrum starts to die and shed and migrate, it collects and falls into that pocket, and it can no longer escape, it can no longer migrate out of the ear. And that skin eventually gets infected, it forms into a plug, and it grows not only outwards into the ear canal, but more worryingly into the middle ear cavity, and then up towards the brain, and it can also go around the back of the eardrum into the mastoid, the entrance of the mastoid cavity, the mastoid bone. And if it's not treated, a cholesteatoma, it can be life-threatening because it can not only start eroding all the middle ear structures, all the middle ear bones and the facial nerve potentially, and the balance organ, but your brain is just on top of your ears, and it can then lead to a brain abscess, meningitis, and it can also then collect into the mastoid cavity, so that's the bone behind the ear. That can get infected. So a cholesteatoma is quite a serious condition. It needs to be treated ASAP. But very rarely, I say very, very rarely, but I've had a few, and I'm going to upload another video onto my earwax channel, because I came across another potential case of a canal cholesteatoma today using the wax scope. So if you're not aware, I've developed another device called the wax scope, and I generally upload procedures with the wax scope on my earwax YouTube channel, so the description will be, the link will be in the description, so do have a look. But a canal cholesteatoma is when, as the skin is migrating out of the ear, so it's managed to get away from the eardrum, but typically deeper in the ear, but it can be in the mid portion. The skin collects typically at the base, the floor of the ear canal. That could just be due to anatomical defects. So the patient's got a natural divot, a trench, a dip in the ear canal, and the skin can get trapped inside. It can also be caused by excessive use of cotton buds, or also sometimes chronic earwax impaction, so the earwax can widen and expand the floor of the ear canal. Chronic ear infection, I think I've mentioned that. Keratosis obturans, so when the skin plug really forms in the ear canal, it widens and it can change the shape and distort the shape of the ear canal. But essentially it's when skin collects in a divot, normally at the floor of the ear canal, normally mid-canal or deeper towards the eardrum. And again, that skin gets infected, it can't migrate back out of that dip, that valley, if you like. So you can see, I'll come back to that, you can see the patient's eardrum. We managed to clear all the occlusion there. Now, on the floor of the ear canal, you can see all this keratin, dead skin, it's ulcerations. I'm going to start clearing this away. I've managed to do a lot already. The patient was brilliant, and bear in mind, she was 100 years of age, she was so still, very cooperative, so it's really, because that was important because of the anatomy of the ear. It's already a complex procedure, which was great. Yes, the skin can again form, dead skin can accumulate into the divot in the ear canal, and that can get infected, and it can start exposing the bone, it can start eroding the bone, and that the floor of the ear canal can then, the bone can get infected, and that infection of the bone, the temporal bone, can spread. It can go up the jaw, and it can go towards the brain, and again that can be very, very dangerous. It can once again cause severe complications. So we have referred this patient to ENT. Now, interestingly, the patient advised that they generally attend the ENT department on the National Health Service in the UK on a regular basis. So what's great is that for complex cases or certain ears that have had previous surgery, and patients are invited back on a regular basis or routine appointments on the NHS at the ENT. It's not typically ENT that perform the procedure, it can be, but typically ENT nurses who are really highly skilled trained, and they have their ears cleaned out regularly. But unfortunately, because of the COVID backlog, and we're having a massive backlog here in the UK, this patient's not been invited back for in excess of 12 months, and they normally used to go a lot more regular than that. Obviously, they do need their ears cleaned regularly. So hopefully we can get them back on the system. I've sent an urgent referral. And you can see what I'm trying to do now is just clear the sides of the ear canal. So the hearing's significantly better already. That's because the eardrum is now visible. There's no occlusion. And interestingly, without the hearing aid in situ, so when it's just their normal ear, they still struggle a lot with their hearing, not only because they've got an underlying hearing loss, but because the canal is completely shut. It's not allowing any natural sound in. But with the hearing aid, the mould itself, it can go through the entrance, because as I mentioned earlier, the entrance of the ear canal is made up of cartilage, the outer third, and that's semi-flexible. And with the hard acrylic mould, it can push through and stretch the ear open. So you can see at the bottom, there's a lot of dead skin, keratin there, and we're just trying to get as much out as possible. It was really difficult because of the lack of space in there, but we do manage. You can see this is a thick layer of epithelial skin. So the epithelial skin is the skin that lines the ear canal and the outermost layer of the eardrum. Yeah, it's the technical term is stratified squamous keratinous epithelial skin. So the term stratified means layers. So this epithelial skin comes in 5 layers. Squamous is the term given to the shape and size of the skin cell. So it's like a pancake. Instead of being a rectangle cuboid, it's more like a pancake. So it's like almost like fish scales. That's another way of describing it. It's almost like fish scales, and you've got 5 layers of those. So the layers are stratified, that's the term we use. Squamous is like the shape of the skin cells, like pancakes, like fish scales. Keratinous means, keratin is a protein, and as the skin, so as I said, there's 5 layers of skin. As the skin is pushed away from the surface of the ear canal towards the centre of the ear canal, that skin gets further away from the blood supply. It's dying, it's shedding, and it loses all the intracellular fluid, so it becomes really dry as well. And as the fluid is no longer retained in the cell, it's replaced by keratin, which is a protein. Now, keratin actually is very useful. It has its benefits. Keratin is hydrophobic. I mean, we don't want water in the ear. Water's bad, but if we do get water in the ear, the keratin helps to repel that. Also, keratin is UV repellent, so it protects us from harmful rays from the sun. In the ear, it's probably going to be less likely we're exposed to that, but that's another function. And keratin normally takes upon this yellowy appearance. Keratin can actually be soft, but in some cases it can be really rock solid. And there was a bit of keratin here that was really hardened, some softer. In the other procedure that I'm going to try and upload today, I shall see, it's been really busy today. I've also just come back from playing football, but I really wanted to get these videos up because if I don't, I will struggle with time during the rest of the week. So in the other one, there was a lot more hardened keratin. They're both very interesting cases. So you can see the keratin here, this is on the back part of the ear canal in the mid portion. It's a bit more wet, and it's very difficult to even gain access to that region of the ear canal because it was so narrow. Now, we're not going to get every little speck out, guys. It's just not, it doesn't just work, it doesn't unfortunately work like that. I'm trying to get as much out as possible for a number of reasons. The anatomy, obviously the complexity of the procedure, the patient's age as well. You know, they were doing really, really well, remaining just still for as long as they were. It can also be uncomfortable in the ear, especially a case like this. So we're just trying to get as much out. And sometimes it just, whatever, if it's wax or dead skin, no matter how hard you try, it's not ready to come out of the ear. And we got to, it's something that I've learned over the years, you just got to accept defeat sometimes. Sometimes less is more, and you've got to accept that you're not going to get every little speck out. And by attempting to do so, you're potentially going to do more harm, because you might bruise or scratch and cause bleeding in the ear canal. And you can see here it's a bit difficult because it's the ear canal around it, it's slightly swollen, so it's almost engulfed that region. So I'm just cleaning the entrance there. The main thing for me, in terms of the patient, their main thing is that they can hear again, because we have cleared the occlusion. Again, I'm just going back to the front. It's a very tedious procedure because we're having to use a fine end, and I couldn't use any drops. I didn't want to use any drops in here. It would have been difficult to put the drops in the first place because the entrance of the ear is collapsed. But also because of the ulcerations at the floor of the ear canal, I don't want to expose any fluid there if at all possible. So the suction probe, the fine end, kept getting blocked. So I was having to constantly, and it's sometimes hard to know when it gets blocked, especially with a fine end, because with the normals on the suction probe, when that gets blocked, you can tell you have this intrinsic feeling, but also the noise changes. It becomes quiet basically, or it becomes very laboured, the suction. With a fine end, because it's a lot quieter, it's sometimes hard to notice that difference. So you can see the rear part of the ear canal is slightly tympanosclerotic. There's all the ulcerations. See all these divots, ups and downs, exposed bone. The skin is inflamed as well. You can see some granulation tissue there, just where I am now. You can see that blood vessel. So that's a blood vessel forming as part of what we call granulation tissue. Granulation tissue is a tissue that normally occurs in the healing process post-infection or during an infection. It's a build-up of connective tissue, and that connective tissue gets its own blood supply, and you can see that there. So again, I'm just trying to clear out the entrance, the valley. And all this skin here, it's not gonna, you just can't really remove that. It's part of it's kind of like, a lot of the skin has died already, and that's what's exposing the bone. And these are the edges. That's the best way. This is the thickened edges of the skin bits that are missing. But you can see there, it doesn't look as it should do, the floor of the ear canal, but we're going to get this patient referred. We've explained to them to avoid water entering the ear and to minimise the hearing aid use. I hope you enjoyed that video, guys. Take care, keep well, and remember, be nice and be kind. Thanks, bye.